Hey guys, welcome to the official breakdown from the 𝙆𝙝𝙖𝙩 Summit. I am Dr. Ryan Lowery here with Dr. Jacob Wilson, ready to break things down for you. And we are going to cover all the topics, literally all the topics. We are going to go topic by topic, give you the breakdown, and literally discuss everything coronavirus related. So before we get started, I'll let Dr. Wilson introduce himself so that way you get to know him. If you don't know him and you're living underneath a rock, can you tell people a little bit about yourself?
Yeah, absolutely. Well, like Ryan said, I'm Dr. Jacob Wilson. Ryan and I have been doing research together for now over a decade. Yeah. Which is a long, long, long time. And this is a topic that we're super interested in. We've looked at metabolic health our entire tenure. We've actually done research that we're publishing that no one knows about actually on the pandemic. Like, we're actually battling the virus in the laboratory that we'll be publishing research on. So we're not only like scientists, we understand metabolic health, but we're actually on the ground floor doing research and battling this along with a lot of other great scientists. So super excited to have the opportunity to talk to you today.
Yeah, and so the reason why we're doing this is because, like, again, this isn't our area of expertise. The metabolic health at the end that we talk about certainly is. But there's a lot of scientific misinformation that's going around. And one of the things that we know well, just because we run a laboratory, is how to break down and understand science. And so we want to jump into that because, listen, it's been 10 months of confusion plus, and enough's enough. And so we want to figure it out. And so we dove into the research to say, what the heck is going on? What's the reality of the situation? And I want to give an unbiased standpoint of saying, hey, here's what the data says, and it's up to us to figure out how we want to utilize or apply that data, right? So are you ready to roll?
Let's do it.
First topic we want to talk about is total cases and relative mortality rates, right? Because I think this is important. A lot of times you turn on media, you turn on the news, and it's just like total cases are climbing and climbing and climbing. And we'll talk about some of the mental aspects later on that this kind of news cycle creates. But what does that mean? Like, what does that actually mean, total cases? Where are they coming from? What states are popular or that these cases are rising? What does relative mortality even mean? And so the first thing I think we agree on, and I think everyone should understand, is that this is a serious virus. It's not something that's, a lot of people will make jokes about it. People are dying, and a lot of people are dying, and I think it's important to understand that first and foremost. Now, for us, I think we need to look at the data and say, again, what are the case rates, relative mortality, and what is going on? So if we look at some of that, here's what we're looking at. We are on pace this year, 2020, to have roughly about 200,000, give or take, more deaths in 2020 than 2019, right? Any death is too many, but that gives you kind of a relative standpoint. If you look at previous years from 2018 to 2019 or 2017 to 2018, typically every year it goes up by about 15 to 25,000. So this year we're up about 200,000 compared to last year, right? So not completely entirely attributed to coronavirus by any means, but it's certainly having some value. You see a lot of these things that are floating around online that say, oh, the death rate... Oh, Siri had something to say. The death rate in 2020 isn't any different from 2019. That's false because a lot of the data they're looking at doesn't count for January. And for some reason, the CDC does not have January's 2020 data on their website, which is really weird. So I did some calculations, and that's what we came up with. Is about 200,000 more deaths this year than last year. So clearly an important issue, and we need to address it. Currently, as of this moment, we have about 303,000 deaths total in the U.S. and a little over 16.5 million cases. The numbers vary, whether it's CDC or world meters, wherever you're looking at. They vary a bit, but those are really what's going on. The question is, who's getting affected? What's the relative mortality rate, and where are these things happening, right? So if we look at something known as the infection fatality rate. So infection fatality rate means the number of deaths divided by the actual infections of coronavirus. That's how you calculate infection fatality rate. With this virus, it's anywhere from 0.1 to 0.3%, right? To give you an idea of what that means, the flu's about 0.1. So up to 3 times as bad or worse than the flu, but some cases like India's data indicates it's about 0.12, so maybe roughly the same as the flu. Now, what have you seen in terms of, and what does the data show with age? What have you seen with age? What's going on?
Well, age is definitely one of the #1 predictors of basically mortality, right? So if you look, basically, if you take kids, people who are at age 10, they're not going to die. It's like 0.002%, right? Guys who are 25 years old, you know, and young guys, right? It's very, very low. But when you go up with age, especially like 75, well, really 50, 65, 75 and above, especially 85, then we start to see the rate increase, you know, exponentially, right? So it is a very real threat when people are like 75, 85, our elderly population. What I will tell you is that when you tease out with a lot of the studies, because I was talking to my dad today, and my dad's in great shape and everything like that, and I don't really think anything would happen. My dad's in his 60s. If he got it, because he's metabolically healthy, there's research that shows that frailty is a higher predictor of mortality than age. It's kind of like, you know, and when you look at exercise and stuff like that, obesity is highly associated. Obesity is highly associated with a lot of disease states. But if you take someone who is obese and they're fit, it actually is not the case.
And we'll jump into that later.
Yeah.
We will jump into that later. But
so
frailty has a big
frailty is the
impact.
point. So my point is that with age, people think it's just age. As we get older, we're more susceptible. My biggest point is that age is associated with frailty. Right. It's associated with obesity. It's associated with all these other things that could be what's causing the problems. And of course, with age, our immune system declines, right?
Correct.
But my point is, if someone's in great shape, you know, and they're in their 60s or 70s, they might respond like someone who's younger, probability might say.
Right. So to kind of sum up that data, if you're under the age of 55, there is a 0.4% fatality rate. 0.4. That exponentially goes up. From when you're 65, 1.4%, but when you're 85, it's 15%. So that kind of shows you that, again, exponentially goes up, but like Dr. Wilson just talked about, a lot of that could be contributed to a variety of different factors. Next, we're going to jump into mass, but before we do that, I think it's important to point out where things are on the rise, because again, not to say that areas are doing the wrong thing, right thing. It's important to understand, like, all right, cool, what's going on? Obviously, if you look at bigger states, they're having higher cases, right? The top 5 states that have the most number of cases, total cases, California, Texas, Florida, Illinois, New York, as of today, right? But if you look at relative cases, that's not the case, meaning the amount of active cases per 1 million people. North Dakota, South Dakota, Iowa, Nebraska, Wisconsin. If you look at those states, metabolic health isn't very good in those states. So it could be, again, why cases are going up. Now, total mortality, and again, we need to look at relative mortality. If you look at total mortality, New York, Texas, California, Florida, New Jersey. But if you look at relative mortality per 1 million, New Jersey, New York, Massachusetts, North Dakota, and Connecticut. And the reason I point that out is because, again, all states are doing different things. And some things, again, maybe are working. We'll talk about that here coming up. Some things might not be working. But I think it's important to look relatively more than total of what's going on in a relative manner versus a total manner, because just because a state's bigger, that puts them at a disadvantage unless you're looking at relative numbers. Right? Would you agree?
Agreed.
So let's jump into the mask, arguably one of the most controversial things. And I think there's 2 segments we need to talk about here. First and foremost, the first question is, and I think a lot of people don't really understand this, is like, one, why am I wearing a mask? Is this to protect me, or is it to protect things going out if I'm asymptomatic or I'm sick? What is the goal of the mask? So first, let's ask the question, do masks help the wearer, protect the wearer from coronavirus?
Well, that's a great question. I think one thing that we can do is we can start to borrow from literature that with influenza, for example, the common cold, You know, there's collective studies that are called meta-analyses, which we've done a lot of meta-analyses before. Meta-analyses take numerous studies, right? Dozens, sometimes hundreds of studies, and they look, what is the overall effect? And when you actually look at the common cold and influenza, masks aren't stopping them. They're not helping at all. The evidence is just not supporting that, right? Which is why when at the beginning of the year, they came out and said, well, masks don't really help. Prior to them kind of switching it up, they said, well, masks don't really help protect the user. And one of the reasons why, I'll ask you that question, particle size, right?
Well, which is something we need to be considerate of when we're looking at mass studies in general. And you guys will have access to this document where we kind of listed all of the studies of everything going on. But the reality is this: when they're doing studies inside of a lab, if it doesn't match up with the actual particle size that coronavirus is, then what good is it? And so some of the studies that do show benefits are showing benefits, but the particle size is like 100 times larger than the particle size of coronavirus. So you can't really interpret anything from that. And so, yeah, there have been simulations that have shown maybe 30% reductions with cloth masks, but again, the particle size is 100 times larger than the actual size of coronavirus, the particle size, which is very, 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 very small. And we'll talk about that in the next section. But there was a critical study that just came out. And again, this is unheard of because in Denmark, they didn't have a mask mandate. So they were able to institute this study, which is crazy. So they basically took, otherwise you wouldn't do this because of ethical reasons, right? You couldn't do this in the US right now, but you were able to early on with coronavirus. And so they did this study called the 𝙤𝙤𝙤𝙤 study. And they found out of 5,000 people, they basically took half of them, had them wear masks, had the other ones not wear masks. And what they found was there was no significant difference, literally a 2.1 versus a 1.8% difference in whether the person who wore the mask got the virus, right? No difference whatsoever. And again, I think the ultimate thing to understand here and take away is the goal of the mask is never to protect the person who's wearing the mask. I don't think that was the intent, but some people are still under the illusion that, oh, this is going to protect me. And based on the data that Doc just talked about and what we see here, that is not the case. In multiple different areas, even from flu and influenza, in hospital settings, the mask isn't preventing the wearer from getting it. The question ultimately then goes to, is it helping prevent or lower the amount of viral load going out, right?
Right.
Is there anything else you want to add in on that section?
No, I think that's the biggest point too. And I think when people are wearing masks, a lot of times they think it is to protect themselves too.
They do.
Like, oh, I'm impervious, right? Because I'm wearing a mask. But that might not be the case.
Right. So let's jump to that second part, right? So we answered the first part is, does it protect the wearer, right? Not so much. The question becomes, do masks help protect expelling to others if we have coronavirus? So what have you seen kind of with that?
Well, the biggest point is we're talking about the thought is that potentially if I'm wearing a mask, that if I cough or if I sneeze, because the disease is spread through droplets. Right. So the thought is that the amount of droplets that someone around me is going to be exposed to will be less, you know, so that's called like viral load. Right. Okay, so that's one of the thoughts. Is now that could be part of it, could be the mask is changing the disbursement of the virus. Maybe it's not coming straight at someone, maybe it's dispersing differently. So one of the thoughts is it might slightly decrease viral load, but again, it's also a very controversial topic.
Very tough topic, and unfortunately, like it's challenging due to ethical standards to properly do studies, right? They won't do studies where they take people, have them put on masks and cough in someone else's face and go, hey, did they get coronavirus? That would be unethical to do, right? So we're basically interpreting this based on models that are done inside of a lab with like mist and certain aerosols, and we're trying to interpret that and go, well, what outward appearance does that have to real world practical application? So again, like you said, I think it depends. Again, it comes down to a couple of different things. Do different masks have different benefits? And what we've seen in the literature is yes, right? You've heard on the news N95 mask, the mask that they use obviously is like the highest tier. But the problem is most people aren't wearing those. Most people are wearing the surgical masks. Most people are wearing cloth masks. Some people are wearing the bandanas, and the data's conflicting. There's some data showing that those bandanas, the ones that people wear around their neck, actually have zero protection, right? Fisher 2020 showed that neck guards and bandanas no protection whatsoever. But a lot of people are out and about wearing that. So there's a lot of confusion. I think this is where we messed up, and we've done a poor job as a scientific community of outlaying this and going, no, this is what we need to do. This is proper mask protocol. These are the proper masks that you should wear, right? Because the second piece that isn't touched on is how to properly wear masks. People don't know, right? In some of the countries that have done really well, or some of the studies that have done things, they have like videos of how to properly wear masks. Here in the US, it's kind of a shit show, to be honest with you. Like it really is. And so people are taking disposable masks, right? Throwing them on the floor of your car, wearing them 6 or 7 or 8 times. Trust me, there's no studies on that, right? You take your cloth mask and you sneeze in it. Say you're out and about and you just happen to sneeze into it. And all of a sudden you throw it on the floor of your car. Then guess what? You put it back on. There's no studies on that. And that's one of the biggest challenges when it comes to interpreting this data is proper mask use and different uses of masks.
And also, you don't know, since there hasn't been studies on it, there could be negative things that actually occur from that. Like, for example, you have your average guy, who's working in the store, and they wear their mask all day long. Like you pointed out, they're going to sneeze in it. They're going to cough in it. Is there side effects from, like, the bacteria building up in there? You know what I mean? That's one thing that you kind of have to think about. Are there even, like, there's obviously social things that we have to even think about, too, especially, like, in kids, when you're trying to recognize facial features and everything like that. So these are all things that also have to be quantified that could be potential drawbacks.
For sure. And so I think there's a lot of questions, right? Before we go to the takeaway from this section, you just talked about what about bacterial growth on some of these masks? What are the long-term effects on healthcare workers? Because there are studies actually from Japan showing that healthcare workers that are wearing masks actually have higher instances of headaches, right? There are some negative aspects to it. Are there negative consequences to a mask society? Psychological consequences of wearing a mask and fear-based behavior? You talked about kids. What about what you're breathing in, some of those fibers? Who knows what some of these masks that people get, they're like, oh, look, they're cool. They got this cool design on it. It's made over in who knows where. What kind of material is that? And you're wearing it for 8 hours a day, breathing that in. I can tell you this, there's no studies on that either. So I think one of the biggest take-home points is wearing masks likely do block some particles, right? I think we're all in agreement with that. I don't think people at this point are, anti-mask, and we'll talk about how I hate that language later on. Like, I think we've come to very anti-this or they're pro that. Like, I don't think people are anti or against masks, so to speak. I think it's the data doesn't support what most people are claiming. They're not the be-all, end-all, right? Staying 6 feet away from each other, great. But like the studies that are done are like with people would be the equivalent of people on top of one another, sneezing and coughing on one another. There is a degree of like, let's use some common sense. Like I can tell you this, for me, I'm of course going to wear a mask when I'm going inside of a store, right? If I see an elderly person walking around the store, I'm not going to walk next to grandma and be in her face and be like, hey, what's up? How's your day going? Like, I think there's some degree of common sense we need to utilize. Like, I'm going to create a degree of separation so she feels comfortable, I'm comfortable, and why put someone in that compromising situation, right? Like, I do think there's a degree of common sense we can bring this. Now, should people be all over each other, partying, doing a million things? No. Like,
my apologies.
Siri agrees. But people shouldn't be doing that. But I think that's a big take-home thing is like, one, masks may help decrease the viral load, right?
Yeah,
we understand that. I think we understand that we need to take into account that all masks aren't the same, period. Some masks are better than others, and we need to be better with our recommendations. We need to have proper mask protocols, right? And I'm guilty of this too. I'm not imperfect. Like, if I have a cloth mask, guess what? It's annoying as hell to go throw it in the washer. I've worn a cloth mask 3 or 4 times, and I think about it, I'm like, that's disgusting. But like, most people probably do, if we're being honest. Who's worn a surgical mask more than one time that's meant to be disposable? We need to be better about that, right? If we're going to institute these and have things. But we also need to not take a myopic view and instead think of what are some of the other repercussions. What about kids, right? These kids, we talked about the mortality rate being what, 0.0002%. And these kids are inside of schools wearing masks when they're learning with facial expressions, and now that's hindered, right? That year that they just spent learning or not learning or seeing facial expressions or like seeing comfort and joy from their teacher, or think about students who are hard of hearing. What do, right? They have some masks that they're now trying to create that have, you can see mouths, but like they're set back an entire year. And not to say that
they might not ever get that back.
They might not, that could hurt them for the rest of their life.
For the rest of, it's this thing about guys, like it's the same thing that, that if you take a kid and you just find out that they have a hearing deficit and you find out a little bit late, they will never recover from it fully. So if you have a kid during development and they don't actually start to recognize happiness, discomfort, sadness, that is the way we communicate mostly is non-verbally. So you might be hindering that kid's ability to understand non-verbal communication for the rest of their life. So it's just something that you do have to consider.
Awful. And then two other things I just want to mention is, one, if you look at IHRSA put out data from gyms, which is interesting. Like here in Florida, most gyms do not require you to wear a mask. And what they found is that they found no statistically significant association between participants having positive COVID results and visiting the gym. We'll talk later about why I don't necessarily agree, and I don't think we either agree that like even in places that are shut down, like gyms are one of the first things to be shut down, and there's no association between being in the gym when the ultimate goal should be focusing on metabolic health, and we'll touch on that later on. Yeah. But that's another interesting insight. But the other thing is that there was a study out of Japan, and this might be attributing to why some studies show benefits with masks, is that even if the mask itself isn't creating a ton of a barrier or it's not enough to block the particle size, they found that people who wore masks in this study with flu in Japan, they had more frequent hand washing, they frequently avoided crowds, they gargled, and they avoided close contact with infected people. So maybe there is this indirect effect, right? Which isn't a bad thing. Like, cool, if I'm going to the grocery store and I'm required to wear a mask, again, am I going to walk next to Granny and be all up in her face? No, maybe because there's that barrier, like I'm going to keep more than 6 feet away from her. And maybe that could be a good thing. Maybe washing our hands with soap and water, good old soap and water, because we'll talk about some of the sanitization things that might be some challenges, is like maybe that's beneficial, right? Maybe that's helping as well mitigate a lot of this. So there are indirect effects. Definitely understanding that it shouldn't be a myopic view of like masks are the cure-all be-all. Can they help? Possibly. They could lower the viral load, but again, there's some other things that we just need to be considerate of, right?
Would you agree? 100%.
So that enough mask talk. We covered that piece. Let's talk into something that's interesting, and this is a different viewpoint that kind of comes out in other viruses, is that there might be this thing known as seasonal variation in general with respiratory diseases. And so it's an interesting perspective, again, because it challenges the interpretation that like, oh, we did a very poor job at social distancing, at wearing our mask, and this is the reason why we're seeing the spike. And there are some people who are challenging this view and saying, whoa, hold on. There was going to be this spike no matter what. And again, we'll talk about lockdowns in a bit, and even with places with lockdowns, there are still some spikes going on. Why? Is because there might be seasonality in these spikes. And so there's this classic study by Shaman in 2010, and they showed that seasonal pattern of respiratory disease can be explained on the sole basis of absolute humidity and its direct controlling impact on the transmission of airborne pathogens. Again, which might be the reason why, and it kind of all happened at the same time. I'm not saying it's 100% this, but if you look, when did we see a huge spike? When did we see it kind of start to settle down? And what are we seeing happen now with the colder months? And in places where it is colder, like New York, New Jersey, some of these places, there could be something there. And there might be this alignment. And Ward predicted this. They said a reduction in relative humidity of 1% was predicted to be associated with an increase of COVID-19 cases by 6.11%. And they predicted this back in May before we even had the big spike. So again, there might be some seasonality because we see this in other aspects of other respiratory viruses.
Agreed, 100%.
So again, Dennis Rancourt says like, hey, maybe we just need to be considerate of the fact that this second wave isn't because we sucked and we did a poor job. Like, could we have done better? Absolutely. Hopefully this conversation will help clarify maybe some things that we need to do a hell of a lot better. But again, it might be that it was kind of this inescapable second wave that we were going to hit anyway due to seasonality changes, and we might face that similar to how we face the flu, right? And have seasonality changes with the flu as well. So just something to be a little bit cognizant of. All right, let's jump into testing, right? And I'm going to say this, excuse my language, but this testing has been an absolute shit show from the get-go. And just absolute nightmare. And I think this has caused, and I think one day you will look back and there will be plenty of papers and things and movies and stuff published about this and written on this, about how poorly of a job we did, right? And how some countries that early on created private-public partnerships and said, yes, this is the way we're going to go. And I think one of them is Iceland, who did a phenomenal job, and I'll talk about that during the lockdown piece. But like, they did a phenomenal job being able to quantify and test, whereas here in the U.S., awful, right? Awful. And so what happened is the FDA granted this EUA, which is Emergency Use Authorization, of hundreds of COVID-19 diagnostic tests. If you remember back in February, March, April, it was like, this test, this test, this test, Abbott has this test, a million different tests, and you were like, I don't know what to do. And we look at this now, we're still seeing this today. And there's two different types of tests, and we'll go over those, the PCR test and the rapid test. But again, the thing that we just need to be careful of is false positives, right? So can you give some example of, like, when we do research inside of our lab, like the DEXA, for example, when we're doing that, what's the degree of variability on a DEXA that, like, if we want to see something that's significant, how tightly does that degree of variability need to be? Okay,
so the biggest thing to understand, like when we're doing a DEXA, which is basically you're scanning someone's body for muscle mass, fat mass, you need to make sure that there's not much variation between tests, okay? So like, for example, you would, if DEXA, for example, had a variation of 5%, okay? You know, or God help us, 10%. Normally within a study, big changes are 5 to 10%. Real change. So if someone lifts weights or they lose body fat, 5 to 10% decrease or increase is huge, right? So let's say my variation of DEXA was 5 to 10%. Then what we would have to do is go back, recalibrate the machine. If it still was in 5 to 10%, then we would need to call the company for the DEXA to come fix it, because it would be failing the test every single time. So with our DEXA, it's like 0.1% most of the time, which means that if someone comes and measures themselves and they have 50 pounds of muscle, they might come back and have 50.1 pounds of muscle, and then come back and have 49.9 pounds of muscle. So that means that if you see real change, it's real. Okay, so we have, in our lab, we have very low tolerance for error, and that makes sense. So that's the biggest thing. Between these tests, you don't want a lot of variation, because if it is, you throw that test out.
And unfortunately, we haven't been throwing those tests out, right? And we've been counting, and it's on both sides, right? But more so, we're seeing a lot more false positives, meaning people are testing positive, but they likely aren't, versus false, like, negatives, right? So again, it's all over the map. And so there's two different ways that people are commonly testing nowadays. And then there's a third one with the antibody test, and we'll give some insight because we actually do antibody testing here. And most antibody tests, like, are done completely wrong, right? And they're all over the map. But the first one is a molecular test. It's the PCR one, the one that everyone thinks is the most reliable. That's the one you get at the medical office, the one you get in hospitals, everything like that. And it is the best that we currently have available, right? It might take a day or two to get your results. That's the one that takes a little bit longer. But there's a study that was done, and they looked at the false negative rate was about 20% when testing was performed 5 days after symptoms began, but up to 100%, which is absolutely absurd, earlier in the infection. So again, 20 to 100% false positive rates with the gold standard of what we're currently utilizing for testing. If that's not alarming, then I don't know what is, right?
It's insane. We would never, and again, our lab, we would never, ever,
you can't.
Ever, I can't even describe to you, we would never use a test in our laboratory, and we've done probably over 1,000 studies. We would never use a test that had a variation that was over 10%. At 20%, I couldn't imagine ever doing something with a test, because you'd never be able to see anything.
You can't. And so, like, that's the gold standard, right? And then there's this other one, which most people, I think, and again, I don't have any data on this, so again, this is theory at this point. I think most people are getting rapid tests, right? We have very little patients here in the U.S., right? But there are people that are going into hospitals, and those people are likely very symptomatic if they're going to get that test. But most people that are like, oh, I got to get back to work, or hey, I just traveled, or hey, I have to go get this test before I go travel and see my friend or my girlfriend or whatever. They're getting rapid tests because they want results very, very quickly, right? So where can you get those? You can get those at hospitals, doctors' offices, but there's also some at-home ones that you can literally just swab yourself and send out, and boom, rapid. So what this looks for is protein fragments or antigens from the virus. And again, false positives are even higher in this, right? So you just heard 20 to 100%, depending upon the time, the test, the procedures. And there's just so many different factors. Who's doing the swabbing, right? You have all these different people. Think about this. If you have a professional doing the swabbing in the nostril or in the back of the throat versus some of these at-home tests or some of these places where you just go into a clinic, they mess up the swab, they expose it to certain elements. That's why there's this entire degree of variation, and it's absolutely absurd. And we're making big decisions on it. Big decisions that don't just affect people's health physically, mentally and emotionally, and we'll get into that aspect about this, predicated on tests that unfortunately have a 20 to 100% false positive rate. And that's alarming, right? That's alarming. And then the last one I want to talk on is antibody test. So again, if you go to LabCorp, they'll give you an antibody test with a finger prick, which is ridiculous, right? Unheard of. The one that we do here at our lab, you have to go venipuncture, get it taken out, and then we take a piece of that blood, a small amount of that blood, and we put it on the thing, and that's where you get the highest degree of reliability. But most places are like, screw that. Most people don't want to get poked. It's easy to get the same amount of blood from a fingertip, but again, that changes the reliability of, and the validity of that test significantly. And so with this, the reported rate of false negatives was 20%, but there's a range from 0 to 30% depending upon the study with the antibodies. And like, people are testing for antibodies, and again, we're making decisions predicated on that. And we had a bunch of people that were like, why are you guys doing, why do I have to come in and get venipuncture? This is ridiculous. I can go to LabCorp and get a finger prick. And I'm like, cool, we're not going to do that because the degree of variability is so freaking off that, like, I wouldn't want to give someone a false hope or this degree of like, hey, you have the antibodies, or hey, you don't, and they do have the antibodies. Like, we want it to be accurate. That's just how we are. And it's insane. It's absolutely, absolutely insane. There's actually this video that is inside of the thing that shows you how absurd this is and challenging with testing. Is that, like, there was an Austrian ambassador, and in this YouTube video, he literally tests Coca-Cola. He like swabs Coca-Cola, tests it, and it tests positive for coronavirus.
That's
live
crazy.
On his video. Like, it just shows you, like, there's this degree of, like, a lot of people who, again, if you are symptomatic, and we'll talk about that when we get to the vaccine discussion, if you are symptomatic and you go get tested and it comes back positive, is there probably a higher chance that that's probably an accurate reading? Of course. But what's going on and where the challenge is imagine you have someone, grandma or grandpa or mom or dad or someone who takes a test and all of a sudden they're asymptomatic, and now they take it, and guess what? The power of the placebo is real, right? And there is studies showing the power of the placebo of like, wow, I now think that I have this virus, and guess what? Now I'm starting to have headaches, maybe a little bit more of a fever, and all these things. Like, think about the downward complications of that, all because we don't have a test that's entirely accurate. And I think that was one of the biggest challenges of, and still today, the challenges of what the U.S. is going through is that accurate testing and mass testing has been a challenge for us since day one, and we still haven't really gotten better at it. So it's a challenge, and it's unfortunately leading to a lot of challenges that we're seeing today.
Agreed.
Right?
100%.
So let's jump to our next topic, lockdowns, right? And again, there's many factors to consider here when we're talking about, are lockdowns beneficial, right? And again, I'll use the word anti because I think that's what a lot of people do. I hate it, but against lockdowns or anti-lockdowns, I don't think necessarily people are going, oh, I'm anti or this. Like, people like to be polar. They like to be extreme in their things. I think it's, if someone were to come out and show, here's the data showing that if we just literally sat in our homes and did not leave for 2 weeks or a month, everything would go away, then people would abide by it. They would be like, all right, cool, I'm good. We'll figure this out. We give help to small businesses. You know what? It'll be tough, but guess what? We don't see that. We don't see that with the data. We don't see that from places. And again, we'll go over different aspects. Some places locked down and saw amazing results, and people commonly allude to New Zealand, right? New Zealand locked down, and they're highly praised, and people look at them. But there are other places, Germany, some of these other places in the UK that went on lockdown. The US kind of went on lockdown. People are going to go, oh, well, they didn't abide by it. People were still out and about. The reality is, if you look at the most of these places, like overseas, they did go on a pretty strict lockdown, and they really didn't see that the lockdown contributed to any substantial benefit of people dying less from COVID-19, right? And that is the challenge. It's not uniform. And here we have a whole list of studies of places that, again, rapid border closures, full lockdowns, was not associated with COVID-19 mortality per million people. Locking down schools, a systematic review showed that no differences. If anything, it might prevent only 2 to 4% of deaths, but we could probably get that same amount with social distancing interventions. Like all of these studies coming out showing, hey, we tried to flatten the curve by doing these strict lockdowns, and in most cases, it didn't work.
No,
it didn't work. Right? What else on lockdowns
well,
do you say?
I think that's the biggest point. It's like you see the response is non-uniform. People can cherry pick some spots, and then you can show other spots like Germany, UK. It's not helping. And so, but you have to do is you have to take a step back and go, and you guys have heard this, but like you can't have, if it doesn't seem to be a cure, but if it was a cure, it can't be worse, right, than the disease itself.
Tough.
And that's the problem, right? So you have to look at all the other repercussions, all the other side effects, all the other collateral damage of lockdowns. So you again, and there's a lot of collateral damage that studies are showing is pretty darn clear, right? Addiction, right? People who have had addictions that are in remission or basically reverting back over at higher rate, 30, 40% reverting back to alcoholism, drugs. You look at the amount of businesses right now that are closing down left and right. They're not even going to, most of them are not going to reopen.
Recover.
The majority of small businesses are not going to recover. Well, now there's people, there's flesh and blood, there's employees, right? Now they cannot feed their family. People are getting evicted. And along with that, when guys are staying home and stress is higher, and they're with their spouse and their kids, child abuse is going up, right? In developing countries, there's data that shows that deaths from starvation
yep.
is maybe as high as the deaths that are caused, and this is in children. Our least vulnerable population to the pandemic are dying because they're starving, right?
And I think this to me, and again, we came at this purely objectively and said, all right, what does the data have to say? And there's a great website. I want to point them out. collateralglobal.org is where we got a lot of this from. And it's basically talking about collateral damage from lockdowns. And there's a lot of stuff that you don't typically think about, right? And you're like, all right, cool. If we lock down, it's just like we think myopically a lot of times, but we can't. Doctors talked about one, addiction, right? People, think about this. People are relapsing back to addiction, right? 33% experienced a relapse in their addiction. That's just in the UK. Imagine globally throughout the world, 33%. And so I want to go through some of these because there are some that you don't even think about. Cancer, for example. And you're like, how would cancer have any impact on lockdown? Like, people are they getting cancer? No, it's being diagnosed early enough to be able to treat the cancer. There's a place, this is in England, they have something known as a 2-week wait urgent pathway. Basically, your general practitioner can encourage you to go get tested for suspected cancers. Those referrals, because a lot of the lockdowns and places are closing and they're not going to see their general practitioner, have decreased over the lockdown period by 84%. And they predict that because of these backlogs, people aren't going to their general practitioners, right? They're not getting tested like they normally would. Their predictions are that this will cost 1,231 additional lives, and this is something that's even crazier, and I want to touch on this for a second. They're claiming 22,635 life years lost. And that's an important piece, because as we start talking into some of this stuff with like child abuse, I think and this is a tough conversation, and it's never easy. Again, like we said from the beginning, any death it's not a good conversation to have. Any death sucks. As a whole, we need to look at something that we refer to as quality adjusted life years, right? The reality is this, and it sucks, because if I'm thinking about my grandfather, and like he's 85, right? The reality is, and as tough as this is, and I know because he's my blood, like he doesn't have a lot of years left, right? I would love for him to live another 30 years. That'd be amazing. I would love for that to happen. I'm trying to do everything possible to make that happen. But a kid who's at home suffering from mental suicide thoughts, from child abuse, who's 5, likely has a lot more than 30 years. And so if we look at this myopically, listen, we all want to save grandma and grandpa. We all want to save our parents. We all do. Like, those are the people who are vulnerable, people who are sick, people who are metabolically unhealthy. If we take a step back and we set our emotions aside and we look at quality adjusted life years, the reality is those kids, those younger part of our society as a whole, and we see this a lot, this happens in the animal kingdom a lot, right? We feed our young, we take care of the young, and the mom cougar or the cheetah will feed her young before, and she'll starve to death to make sure that they're taken care of, right? We live in a very different world with humans in the US, but if you take a step back and put emotions aside and think about that for a second, there's a lot of quality adjusted life years that are being impacted indirectly from some of these things when we're looking myopically, right? Things like cardiovascular disease, right? Cardiovascular disease is taking a huge hit. People aren't going to the doctor and getting checked out as much. There's delays in getting diagnosed. Likely this is going to lead to a higher amount of people dying from cardiovascular disease, and we've seen this acutely in the UK. People dying at home from cardiovascular disease because they're not going in and getting checked to understand if there's any blockage or anything. Doc already mentioned hunger and starvation. There's the World Food Program is predicting that these places that are low to moderate income places, again, even here but overseas, will nearly double to 265 million by the end of this year. And that's just this year. What happens if this continues into next year? We estimate there will be 128,000 additional deaths in children younger than 5 years in 2020, right? We're looking at total amount of deaths, and yes, I think I said 303,000, and that's a tragedy, right? And no death, again, I'm going to repeat myself, no death is enough or too many. Like, people are dying, and it's a problem. Kids, 128,605 predicted kids under the age of 5 will die throughout the world from hunger and starvation alone due to what's happened during this pandemic. And is it solely lockdowns? No, but that's a large contributing factor to a lot of this, right? Alzheimer's and dementia. They did this study with a third of people living with dementia. 32% reported apathy or a sense of giving up because they don't have any human connection, because they're locked into their house. They don't have their home care worker, and now they feel like a burden on their family, right? They don't have much time left anyway, and dementia is a very quick and deteriorating condition, and 32% of them just feel like giving up. Abuse, which breaks my heart because this is both abuse, primarily female, it's also happening to males, but child abuse. The fuck, child abuse? Like, that's brutal to think about. And these are things, cool, we're sending kids home and they're working from home with their parents and schoolwork, or they're in an abusive household, and guess what? Now they're there all the time, and dad's now relapsed into becoming an alcoholic, and now that abuse just gets 10 times worse. Studies show a 60% increase in emergency calls from women subjected to violence during lockdowns. We're looking at fewer referrals inside of schools, child protection medical examinations, basically teachers that see children that come in with bruises or things on their face. It was down like 38% this year because, again, kids aren't in school. You can't tell that over Zoom. That's brutal. Kids, if you look at one hospital, did this study where they looked at how many kids, children, they're very, very young, these children are coming in, and they looked at the past 3 years of how many kids are coming in with suspected head traumas that were like accidental head traumas, right? Which is commonly seen in abuse. Over 1,493% increase in abusive head trauma this year compared with the last 2 years, right? And we could go on and on and on. The joint investigation by the Women's Aid found that 2/3 of domestic abuse victims were subject to more violence from their partners during lockdown. 2/3 of these women who are dealing with abuse already have more abuse during lockdowns. 3/4 of women said it made it much more difficult to escape their abusive partners. They're trying to, and now they're locked down, and now they have no idea where to go. Like, there's these other repercussions that we need to think of. Another one that I want to touch on really quickly, mental health and suicide, right? Commonly gets discussed. It's a challenging one to look at, and I think we're going to see this unfortunately pan out in the next 1 to 2 to 3 years because we're usually a year to 2 years behind, but there's inclinations that it's getting very bad here in the US, and it's gotten bad internationally. 1 in 5 adults, they did this survey in Great Britain, said that 20% of people were likely to be experiencing some form of depression during the COVID-19 pandemic in 2020 when we were in lockdown, right? 42% said their relationships were being affected compared to 20% that just said they had mild depressive symptoms. Like, insane. They did a study where they took people over in Great Britain. They gave them a survey. And again, this is survey data, but it's interesting to look at. They compared them to prisoners in jail. And in these regions, people in lockdown felt more hopeless than people that were in jail for the first time, right? What do you think that's doing to their overall mental health and stress, right? Brutal, brutal stuff. Now, if you look at suicide, the top 3 contributors to suicide, social isolation in general, not just during coronavirus, social isolation, online bullying. Do you think online bullying is going up or down during periods where kids are at home and they're on their computers all day long? Of course it's going up, right? Lack of human touch and connection. It's one of our essential needs. And if you're not getting it at home or you're not getting it from your friends, your family, you're lacking that sense of need. Like, percentage of respondents who had suicidal thoughts under lockdown or shelter in place significantly went up from April to May to June, significantly. And this isn't new. We saw this with the SARS outbreak in Hong Kong. We've seen this previously, that these spikes in staying at home or having these complications is leading to a lot of these complications for suicidal thoughts. And it's awful. And the last one I'll just touch on here, Japan in October, there's an article that came out. More people died from suicide last month, meaning in October, in Japan than from COVID in all of 2020. They had 2,100 suicides in October. That is fucking brutal, right? Brutal. There's a whole host of things that could have contributed. People are, again, lack of human connection. People are losing their jobs, being furloughed. Businesses are closing down. These are indirect things that we don't necessarily think about and we don't see, but that are happening behind closed doors that we need to be aware of, right? Doc talked about poverty. Homelessness in the UK amongst young people is climbing. 49% of children who typically get fed school meals, that might be the only meal they get. Guess what? They're not going into school. Are they eating? 49% of students are no longer getting that meal. That's a problem. Now, small businesses, right? Before we jump into small business, we can look at other places that had lockdowns. New Zealand, like I talked about earlier, often gets looked at. They did a great job. And a lot of people are looking at them. They went into a strict lockdown. They had proper protocol. They had amazing testing, isolation, everything. They had great problems. Iceland scienced the hell out of this virus. They sequenced the genome. They tested everyone. They have a 10 times lower mortality than the US and UK. They were the ones that I was talking about earlier on with the testing that did very well with public-private partnerships and dominated testing early on. They found that 43% of COVID patients were asymptomatic, which was amazing. And they're still doing very, very well, and there's studies published on Iceland. So again, there is something we can learn, but again, it's not uniform across the board, and there's different parameters. People in Iceland are a hell of a lot more metabolically healthy than people in the U.S. Significantly more metabolically healthy. You can't translate that data and go, oh, well, New Zealand and Iceland did it, so we could do it over in the U.S. It doesn't pan out that way. We are not as metabolically healthy, and we'll talk a little bit later on about steps that we can do to do that. And like Doc said, there's studies with small businesses. 60% of business closures, according to Yelp, are permanent, meaning they will never recover. They will not come back. I was in New York visiting a friend, and like you see these businesses close down that were there for 20, 30, 40 years, and they will never recover. As of August 31st, 163,000 businesses have closed, which was a 23% increase since July, and I think you're probably going to continue seeing that, especially with the lockdowns now continuing. There's no way. There's no way places in California, New York, a lot of these places that aren't allowing indoor dining, it's impossible. It is absolutely, absolutely impossible. And without some type of government aid, and we won't even get into the aspect that, yes, some people abuse the government aid. Most small businesses did not get enough to be able to survive this kind of impact, right? So that's the toughest piece. And I know that was a little bit of a ramble about lockdowns, but I wanted to touch on each one of those points because they matter, right? They're indirect things that we don't typically think about.
100%. 100%. I think it's very necessary to go into that.
So that's tough. It's tough to think about. And so now we're going to jump into a topic that's probably even more controversial, right? Something that people will sit up and your Uncle Joe on Facebook has an opinion. Your Aunt Sally read something on Reddit and she's going to post about it. And she thinks the vaccine's going to give you horns out of your head. And Uncle Joe said, we can't function without it. And there's just so many different varying opinions. But let's talk about what the data has to say. And they're based on the Pfizer. We're going to talk specifically about the Pfizer and Moderna data. But let's start in first, kind of like where do you want to start on vaccine talk?
Well, I think we start with just talking about what is the COVID virus. Because you kind of have to understand. Let's say you guys are scientists. You have to understand what is a virus because that's how you attack it, right? So what you have to understand is when it was first reported in 2019, so it's called like SARS-CoV-19 because it was discovered in 2019. Within a month, they had sequenced the virus. So they knew, lightning fast, they knew what made this virus up. And so what is the virus? What are we facing? Well, first off, like Ryan said, this virus, it's so tiny. You take an electron microscope, and I'm telling you, this is you take the most powerful electron microscopes, and it's very difficult to see this, right? Well, basically, it's what we call an RNA-based virus. And what is RNA? The best way to describe it is like if basically it's kind of like instruction. So if you have instructions, a blueprint, okay? So RNA is a blueprint, okay? So if you're building a home, you have a blueprint, you go out there, and then they get the wood, and they get, the cement, and they have the workers, and they start building it. But they can't build without the blueprint. So RNA is basically kind of like that. It's like that Xerox. It's a Xerox copy of the blueprint. Because, for example, in our own cells, we have DNA that has a blueprint. We make a Xerox copy, and the Xerox copy of the blueprint is RNA. These are RNA-based viruses. Now, it's controversial whether a virus is alive or dead. Most people, by definition of life, would say that a virus it's dead. It's just sitting around, floating around. But this virus has the RNA, it has a blueprint for 26 proteins that make it, okay? That has instructions to build a coronavirus. So you have this strand of RNA that codes for these proteins, okay? And then you have like a lipid membrane. So it's encased in an envelope, right? So you have this strand of a blueprint, the RNA. You have basically this envelope around it. And on the outside, kind of why we call it coronavirus, it looks like there's like a crown around it. And that crown is made up of what we call these spike proteins. So you have like this corona here, and you have these spike proteins that are all around it. What are those? Well, these spike proteins that kind of form this corona or halo around the virus basically are they bind to cells. That's what allows a virus to bind to a cell. So again, you have this strand, this Xerox copy, this RNA. It's enveloped in an envelope, and on the outside are these receptors that we call spike proteins. Now, what people mostly think is you go in an elevator, someone sneezes, boom, the virus hits you and you're infected. It's actually not that simple. We have a very complex immune system. Say you go in, someone sneezes, you go in an elevator, the virus gets taken up. And let's say, okay, so the lungs are probably the most area that most people think about, but there's huge symptoms everywhere, muscle pain everywhere, okay? So basically, what ends up happening is that the virus goes in, and these spike proteins have to bind to a cell on a receptor, okay? Kind of like a lock and key type of thing. So they have to, like a spaceship has to dock, you have these receptors, and the spike proteins have to come and bind to these binding spots on cells. If you don't have the binding spots, you can't get infected, right? Mm-hmm. So these binding spots are, these receptors, they're called ACE2, okay? ACE2, or angiotensin converting enzyme 2. ACE2, angiotensin converting enzyme 2. So basically, you have spike protein, you have receptor, spike protein binds to receptor. Once it binds to receptor, okay, it goes through a series of several complex processes where basically it can get taken up by the cell. Once it gets taken up by the cell, guess what it does? It uses your cell as a manufacturing base to reproduce itself. It reproduces itself and then releases it reproduces because what does it have? The blueprint. It's like, here, you go to the homemakers and say, here's a home. Start building it. That's what they're doing. You go to the cell, you have the machinery for the cell, boom, you put the instructions to the machinery, which are called ribosomes. You make all these copies of the virus, and then boom, you release those viruses out into the body. And that's viral load. The more this occurs, the more virus you make, the higher the viral load. Now, but the thing to understand is this. Before, your body has defense mechanisms. If you look at like your lungs, if you look at the cells in your lungs, around the lungs you have mucus. Mm-hmm. You guys know when you blow your nose, that's what's coming out, okay? So basically, if you think about it, what we can do is, first thing, this virus, if you don't get a lot of it, if you have lower viral load, maybe it gets stuck in the mucus, and maybe you blow your nose and you get rid of it. Or actually, sometimes what happens is your cells are kind of beating the virus, the mucus up. You can blow your nose, you can hack it out, or you can swallow it. You swallow viruses all the time, and you know that the virus, when it gets exposed to the stomach, dies. Mm-hmm. Okay? So basically, what vaccines are trying to do, there's a couple different ways. Old school, why vaccines? Well, how could we do it so quick? And why did it take so long before? If you look at the original SARS COVID virus that came out several years ago, right, and the MERS COVID virus that came out, you're talking like 24 to 36 months before they even came out, started going into phase 1 trials, and by the time they did, it pretty much was over with, and they stopped investing money in the vaccines. Mm-hmm. Well, if you look at original vaccines, take polio, for example. What were the original vaccines? They were originally, in the original vaccines, and they're trying to do this now too, that's not the vaccines got released, but you take the vaccine and you introduce either a completely inactivated form of the virus where it can't replicate, or you introduce a weakened virus, okay, where it can't really replicate that much. Well, you can see why that could take years to develop, because makes sense. Oh, I've inactivated the virus. What if 10% of it's still activated? Oh, I've made it weakened. Is that enough? And so now you're literally introducing something that could still infect you. So you can see why it could take years and years to develop this. So what do RNA-based vaccines, Pfizer, Moderna, what do they do? You tell me, repeat back to me, how is COVID binding to the cell? Remember, RNA, envelope, spike proteins on the outside of the cell. What do those spike proteins do? They bind to the ACE2 receptor. They bind to that receptor, okay? So basically what ends up happening is we have sequenced the entire genome of coronavirus. We know the sequence of that spike protein. So what's the war? What are these viruses? Moderna and Pfizer have taken proteins on that spike protein. Let's simplify it and just say they took the spike protein. They create RNAs. They create a Xerox copy. Now, the spike protein by itself doesn't cause harm. By itself, it's not causing harm. It's binding and allow it to entry. It's the virus that's causing the harm. The spike protein is not necessarily by itself something that's harmful. So you take RNA, you make a Xerox copy of that, you envelop it in an envelope, you inject that into you. Now that goes into your body. It gets into the cell environment, and your body starts making the spike proteins, or actually part of the spike protein, okay? And now your body goes, I don't know what this spike protein is. I'm going to attack it. And so it sees it as a foreign invader. It's going to attack it, which is why, like, we'll talk later about the side effects of these things are what you would normally see if you have an immune response. Fever, fatigue, pain, all this stuff. Because your body's saying this is a foreign invader. And what does it do? It says, I don't like this spike protein. I'm going to create what are known as antibodies against this spike protein. Antibodies or immunoglobulins, which we talked about, we test in our facility, ASPE. They go, okay, and they bind to that spike protein, okay, and they basically target it for elimination. They target the spike protein to get destroyed by your immune system. Okay, so now, let's say that we introduce Moderna, Pfizer, what do? They introduce these in, your body creates antibodies, now you're faced to the real virus, and your body goes, I know that spike protein. It's got the antibodies for it. It attacks the virus, okay? And now the virus can't bind, right? And if it can't bind, what happens? It gets stuck in the mucus. It can't get into the cell. It can't replicate. It gets beat out. You swallow it, kill it. You blow your nose. It's gone. And so that's kind of the theoretical basis for these actual viruses. And also think about it, why they can fast track things so readily, because they're trying to target something that's a relatively inert portion of the spike protein that theoretically shouldn't cause safety issues outside of your own immune responses.
Right. Beautifully put. So just to recap, here's what coronavirus is. You have the vaccines that they're creating are basically mRNA, right? That is coated with this lipid bilayer, right? Because if you just were to introduce mRNA and you bring it into your system, it would die. It would get eaten up, destroyed immediately. So they need to basically put this guard around it, which is that lipid bilayer, which is actually the rate limiting step, which is why we don't have this scaled to 1 million units yet, because that's the difficult part to make. Is like, how do you provide this barrier protection that isn't going to have as many side effects and be able to protect this mRNA, and then they're replicating that and basically saying, cool, how do we make sure that it codes for the spike proteins that are on coronavirus so that way the body can build antibodies. So great job explaining that. One big question, so before we go into the trials, actually let's go into the trials, because then we'll talk about like, hey, what about, will it affect my genetics? What about female infertility? Does everyone respond well to it? Yada, yada, yada. So let's talk about the trials that they did. So they basically fast-tracked this thing. They called it Operation Warp Speed, and they got it done fast. And I think there's huge kudos that need to be given to getting this done fast, because it's unheard of. There are some concerns of like there were steps that were skipped because we went straight to phase 2, phase 3. So I understand where people's worry is there. But let's look at what's actually been done with both. Pfizer had to just recently present their results and their safety data, and so did Moderna, literally less than a week ago. So we have the results of those trials. Do you want to go through them? Or
yeah, sure, absolutely, yeah. So you guys hear 95% effectiveness. What does that mean, right? What does it mean to be 95% effective? You know, and so the thing to think about is how they calculate that. So basically you look, and if you look at the Pfizer, you had, first off, both the Pfizer studies and the Moderna had very similar outcomes and very similar results. So you explain one, you kind of are going to explain the other. Right. But with Pfizer, they had about 43,000 people at first, and it ended up being at the end, people who actually moved into the trial where they get data was roughly around 37,000 people, okay? For people who didn't drop out or people who haven't had the virus before for the most part. So anyway, you had roughly 40,000 people, close to 40,000 people. And what you do is you split them into a placebo, randomly, blinded, into a placebo or the actual vaccine itself. And to understand, you're getting 2 doses. Now with Pfizer, you're getting a dose day 1 and like 21 days later, whereas Moderna is a little bit longer. Okay, it's about a month, about 30 days. 30 days. So it's more effective when you're taking it 2 doses, right? So what ends up happening? Okay, what they do is they give these doses, and how they're judging effectiveness is this: you look at who has COVID-19 the same way CDC determines whether we have it. What happens if you get a fever or you start getting a cold or you start sneezing or you feel muscle pain? You go, oh my God, I might have COVID, and you go get tested. Kind of same thing here, okay? So what they do is within 7 days after the second dose, that 21 days after the first dose, within 7 days, they looked at reporting of symptomology and then following it up with the gold standard tests that Ryan talked about, right? So basically they go in, they go, I have a fever or something like that. So, which by the way, most people do get symptoms. Most people will get immune responses. They'll get fever, or they'll get, and I'll let you talk more about those symptoms. Fever, muscle pain, weakness, fatigue. So people will get these symptoms because your immune system's launching a response against the spike protein. But then you go get tested. So of the people, again, within 7 days of the second injection, basically on the Pfizer, the people who reported and tested positive, you had, of those about roughly 40,000 people, you had about 170 people tested positive for COVID. They had the symptomology and they had the actual test from the sample that they got that confirmed that they had COVID. Okay, of those 170 people, 162 were in the placebo group and 8 were in the vaccinated group. Okay, so this is where they get the 94.6% or 95% efficacy, because they're basing it based on these 170 people were affected. Of those, 162 were the people who were on placebo. 8 of them had the vaccine. They looked further at severe infection, and you see a similar breakdown. The majority of severe infections, which are more catastrophic, were the people in the placebo versus the vaccine. Okay, so that's basically the trial. But the main thing to understand is how are they determining this efficacy is, hey, I got symptomology. Cool, I'm going to go get tested. And I tested positive. And of those, 162, 8, that determines your percent. Same thing with Moderna. When they got to the 95 point, like 95 people tested positive, they unblinded the people who were not a part of Pfizer. This review board, they unblinded them to those people. They looked, 90 people in the Moderna trial, 90 people were in the placebo, 5 of the people were in the vaccinated. Your 95, 96% efficacy. That's how they're determining it. So, and I'll let Ryan. Now, Ryan, I know one thing we were talking about earlier this morning is there are side effects, obviously, to getting this.
Sure.
What do those side effects look like?
Yeah, and you touched on a lot of them. A lot of them are very similar to what people experience when they get COVID. So, people are, if you're looking, I mean, they're similar. Pfizer and Moderna, most of them, like 91% of people experience pain at the injection site. 70% of people experience fatigue. 60% of people headaches. Muscle pain, 60%. Joint pain, 45%. So, like, there are some side effects that you're going to deal with getting the vaccine. Now, one that gets blown up a lot is in the Pfizer, there were 4 cases of Bell's palsy in the vaccinated group. In Moderna, it was 3 cases of Bell's palsy. There's a lot of factors that could have contributed to that. It could have just been people typically get it throughout the year, but maybe that just kind of accelerated it. that typically goes away after 6 weeks, 6 to 8 weeks. It kind of resolves itself. So we'll see what happens in that regard. But I think the results were good. I think they're promising to some degree. I think there are side effects that people would need to be cognizant of. I think the ultimate before we go into that and do a summary on it, I think one of the big questions that people have is, will this alter my genetics? No, it will not alter your genetics. It's almost impossible to get something into the nucleus, which is where you alter genetics. Damn near impossible. This will not do that. Right?
Yeah, because basically this is not getting into the nucleus. It's going. You have the environment, and then you have the nucleus. This is occurring in the cytoplasm, which is outside of the nucleus. And again, they're kind of coding for somewhat of an inert part of the protein, right? So I think that's, again, theoretically, RNA vaccines should have a much higher safety ratio. Of course, this was done very rapidly. Of course, steps were skipped, right, for this process. We're using new technology here, right, which should theoretically make things safer, but it is what it is. Yeah, so we are cutting some steps, but theoretically, things seem to be safe. And of course there's controversy around it. Like one of the things we were talking about this morning is, can this stop infection, right?
Well, I think before we jump into that, because I want to touch on female, there's a myth going around with it's going to cause female infertility. Definitely a big myth that's kind of going on. And on paper, the mechanisms sound like they're sound. And the reason that happens is because the spike protein that Doc just talked about on coronavirus is similar to something called C19, which is a protein that is involved in placental development. So the thought on paper is like, if you develop this protein, will you develop antibodies to this thing that's supposed to help the placenta of my baby? Very, very, very different. The antibodies will not attack C19. Even though it's structurally similar, it's different. And if that were the case, then people who had coronavirus, females, would be reporting higher rates of infertility, not getting pregnant. And we're not seeing that, at least yet. So that's definitely a myth. So some questions, like you just pointed out, I think these are points of consideration. Is both of those trials? I mean, let's be honest here. There is big money in this, right? So this vaccine alone, I forget where the number. Oh, right here.
30 billion.
30 billion. So the vaccine industry as a whole, typically in 2019, I believe, was about 27 billion. This vaccine alone is estimated to be a $30 billion vaccine, right? So there's a lot of money at stake here. So we do need to be cognizant of that, right? Not saying someone's going to jade results or do anything. The results were good, all right? They're good. There are things that we need to be cognizant of. It's like, one, I think we're at a point where I think it should be a voluntary decision for people to take the vaccine. If they want to take the vaccine, don't take it if they don't want to take it. There are ways that you can enforce that. If people are trying to enforce it, cool. If you want to get like Qatar Airlines, I don't necessarily agree with it or disagree, but the reality is like they're saying if you want to come on my airline, you need to be vaccinated. Places are going to start doing that across the world. Like if you want to come visit my island, you need to be vaccinated. The ultimate question to me, and you have some interesting insight on this as well, it's like for me personally, if it was clear, right? Because again, personally, being younger, metabolically healthy, I do not have concerns that I would be able to fight off the virus myself. The biggest concern that I have, which would break my heart, is me getting coronavirus and being even asymptomatic and transferring it to someone else who can't handle it. I think everyone feels that way. Like, I don't think anyone's like, I don't care. I'll if I pass it on, screw them. They're supposed to die. I hope not. I don't think people feel that way. But the reality is we don't know. So the question ultimately becomes like, all right, well, I would definitely highly consider it then at that point if I were to go, all right, taking this vaccine will help clear or not allow me to transfer maybe as much of the viral load because I'm blocking it maybe. Maybe that's how it's working. The data is inconclusive because it's still so early on, but maybe that is the case. Maybe if you do get the vaccine, you will not have as big of a viral load, so you're less likely to give it to grandma, grandpa, mom, dad. Is that what you're indicating?
Yeah, I think here's the biggest thing. People will grab onto every statement, right? So the CEO of Pfizer, they asked the CEO of Pfizer in an interview, they go, do you think this will stop basically spread of infection? And he goes, that's inconclusive. You know, for lack of a better, I'm paraphrasing, he said that's inconclusive basically. And so of course, 1,000 YouTube videos came out next all saying that the vaccine will not stop spread of the virus. Articles, it trended on Twitter. The vaccine will not stop spread of the virus, all because the CEO of Pfizer said this. Well, the CEO of Pfizer, every word he says, every statement he says could mean a massive lawsuit. He has to always take precaution. I mean, as do we, right? So what I'm going to tell you is, yeah, we don't know. What I will tell you is this, though. Typically, infection tracks along with the severity of the symptomology of the disease, right? So the overwhelming majority of vaccines that are out there that control the symptoms, control the spread. There's not a lot of reason to believe that this wouldn't do the same thing, okay? It's going to decrease viral load. Think about it. If you're stopping replication, why are you stopping symptomology? You're creating antibodies, which are eliminating the virus and stopping it from replicating or lowering its replicable ability. You're lowering viral load. You're not just, it's not like you're taking an ibuprofen and treating the symptoms. Right. You're literally attacking the virus. So if you're going to decrease the viral load, you're treating the cause, which results in the symptoms. Okay? And so that theoretically speaking, by all hypotheses and theories, you should theoretically limit or decrease the spread of the virus. Again, those long-term parts of the study, this was very rapid. Like the Moderna looked, okay, cool, we got 95 cases or whatever, we're 95% beneficial. And same thing with the Pfizer, cool, 170 people, 162, we're 95% successful. This is very early on. We need a lot more duration, this to be carried for a long duration to say it's stopping the spread. And we'll know a lot more as this vaccine gets distributed. Because like Ryan said, Qatar Airlines, to get on my airline, you need to have this. I think, and I'm not, but a lot of ticketing agencies that we all have apps for that we're going to buy concerts on, you know, eventually again, they're going to want you to have proof before you walk into that concert venue that you've got vaccinated. So it's the vaccine's going to go. It's going to spread. I agree with Ryan. I think it should be voluntary, but it's going to spread, and we're going to find out whether it creates immunity. But I'm just saying that, like, just because the CEO of Pfizer said that doesn't mean don't interpret that to him saying that it doesn't stop the spread of the disease. Right.
We don't know.
We don't know.
Theoretically, it should.
Theoretically, it certainly should help.
So one of the last topics that we'll talk about with vaccines before we jump into nutrition, exercise, and supplementation and wrap this up. One of the biggest challenges that we're going to face is the people who are the most susceptible to severe complications from coronavirus are the metabolically sick, right? Frail, people who are obese. And commonly what we see is people who are obese, for example, their immune system is already compromised, and based on influenza data, other vaccines that have been used, they do not respond as well to, again, influenza, hepatitis B, tetanus, and rabies. Their capability is like, they might not even respond. Hence, we'll jump into like why I think it's absolutely absurd that we haven't made nutrition, exercise recommendations to prepare people for this. It's always been vaccine, 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 work on. Well, guess what? People are getting sicker and fatter and more overweight and more metabolically unhealthy and all of these things while we're doing that, being locked down. And guess what? We're putting them in a worse position to respond to the sole thing that we're trying to create to help them. It does not make sense. And we looked at it myopically the entire time. And there's actually preliminary evidence that COVID infections linger for about 5 days longer in people who are obese than people who are lean, right? Yeah. It's lingering. It's not clearing. There's a lot of problems there. A lot of problems there. So definitely something we need to be cognizant of.
Exactly, and that's what we're talking about, 100%.
So last thing, and this is our meat and potatoes, our meat and cauliflower. So this is where we know a lot about, and so how can nutrition, exercise, and supplementation play a role? Before we jump into nutrition and exercise, I think there's a very important thing to understand is that this situation of what's going on could very well be, if we do the right thing, and hopefully you're tuned in and you're listening to this at this point, this piece and what we've gone through could be the start of the biggest health revolution of our time. It should be. Like, we had an opportunity, and this is one of the biggest challenges that we missed early on. And this is the again, I don't like to dwell on the past. We're here to talk about what we can do today to get into the future, but we need to emphasize that early on in February or March, we would be in a lot different situation, a radically different situation, if we started talking about, hey guys, let's cut out processed carbohydrates. Let's lower the amount of refined sugars. Hey, McDonald's, Burger King, all you guys, listen, I understand people are without jobs. Maybe let's limit your hours and really only try and allow people who are really struggling for food to go get that. But everyone else, here's some subsidized, better options, right? Here's how we need to focus on food. Guess what? We're going to run on all the channels. We're going to run every hour on the hour movement tips of here's how to move at home. Here's the importance of getting 10,000 steps a day. We're going to do a global tracking of like where are your steps at, and we can compete throughout the world. All of these different things. We'll get into vitamin D, like should have been a universal thing to just go outside and get some freaking sunlight every single day. And we fucking blew it. We missed the mark. We missed it. And like largely that probably cost thousands of lives.
Crashed and burned.
Brutal.
Crashed and burned.
Brutal.
Horrible.
Brutal.
Ryan, the biggest thing I can't even emphasize enough what you just said. Guys, listen. There's a lot of theories to how this coronavirus spread and how it was developed. Okay, there's a lot of theories. A lot of theories. Okay, we're not going to get into the controversy of that, right? Yeah. One of the number one theories is that it came from bats, because what happens is bats can carry coronaviruses that don't really impact them much, goes to an intermediate animal, and then it gets to us. And one of the theories is like, okay, that's what happened in wet markets, right, in Wuhan. Do you guys know, I'm going to ask you guys this question, how many estimated coronaviruses are in bats, right?
Good question.
Just take a guess. The thought is that there's like 5,000. Yeah. So what happens, we get this vaccine, everything's jolly, everything's great. What about COVID-25, right? What about COVID-35, okay? What I'm telling you, friends, is this. Okay? This is not the last pandemic. Okay? And I'm telling you, we sit here and we talk about masks and social distancing and all lockdowns. Guys, the number one thing we need to do, maybe the most important people in our, that could address this disease are exercise physiologists and nutrition, people who are experts in nutrition. Because I am telling you right now, in order to pandemic-proof ourselves, look at the numbers. Why are 25-year-olds, why are people in their 30s, why are people who are metabolically elite why are they asymptomatic, right? If Ryan got the virus, he probably wouldn't even experience any symptoms, right? Why is this the case? We need to pandemic-proof ourselves, okay? And that is where movement comes in. Ryan's right. I am frustrated. I get so frustrated every single time I see people come on TV and the only thing we talk about are masks and social distancing. And this whole last 8, 9, whatever, this whole last year, we have not created the largest health revolution in the history of our country, in the history of the world. And that fact right there is why those 5,000 coronaviruses that are sitting dormant, I'm sorry, guys, listen. No, not all of them can infect humans, but the point is there's another pandemic coming. And our ability to fight that pandemic doesn't lie in a vaccine. Yeah, it's great for this one. It lies in our own immune system's ability to fight. And that really is where exercise comes in, and that's where nutrition comes in.
Powerful. You're right. And so I'll touch on nutrition just a little bit, and then we'll jump into exercise, and we'll finish it up with supplementation. But I think we hit the nail on the head. You know this. If you're watching this by now, nutrition plays a huge impact. It plays an impact on our immune function. There are studies. So this first study shows that even just a 75-gram oral glucose tolerance test, which is commonly done to look at diabetes and some of these other aspects, they do oral glucose tolerance tests. It's just 75 grams. they found that when you do this, how long was it? For hours thereafter, you have decreased immune function. So think about that. Just think about this for a second. We get in arguments. People will fist fight. People will scream at each other in the store if someone's mask isn't covering their nose, or if they're on an airplane and they take it down. But the guy on the airplane is sitting there, or the girl on the airplane sitting there, drinking a 7-Up with 50, 100 grams of sugar, eating snacks from the airplane. Guess what's happening to their immune function? They think that this bodysuit that they have on is the protection. They're screwing up their body's own immune system just with that one snack, that one meal. And think of how often that happens over and over and over again. We're watching Netflix, rewatching Tiger King for the 10th time, and sitting there eating Uber Eats and eating ice cream. We're destroying our immune system, yet we are afraid to walk outside and get some sunlight, which could actually help, right? Think about how backwards that is. Nutrition plays an impactful role. They've looked at type 2 diabetics. People with type 2 diabetes, they compared type 2 diabetics that have a high amount of insulin that have to inject versus people who don't really have to inject any insulin. There was, with COVID-19, the insulin group, mortality rates were 27.2% compared to the non-insulin group of 3.5%. Wow. Insulin and leptin, all of these things are having an impact that's predicated and can be controlled by nutrition. And we know that a lot of the underlying conditions, hypertension, obesity, all of these things, obesity, 50% of patients who were hospitalized with coronavirus were obese, right? That's insane. That's absolutely insane. And nutrition can play an impact. And we're not discussing it, and that needs to change. It absolutely needs to change. And so before we jump into exercise, one of the other things that Doc talked about, and that I'm sure you're going to talk more about, is ACE2, right? This receptor that's important that coronavirus binds to. Guess where it's running rampant? Guess where it's very, very high in? It's not muscle tissue. It's adipose, right? People who are more overweight have a ton of ACE2, a ton of it. And that's a big problem. And so nutrition plays an impact, and let's talk about how exercise plays an impact.
Well, you know, one of the things, our really good friend, Tony Robbins, he always says, change your physiology. He targets physiology first, okay? So that's what we need to do. And actually, it's funny because, like, exercise, like the first thing he'll do when you go to his events is he does movement activities. He does movement activities. It's interesting because when you see he changes your physiology, it's the first thing he does. One of the most successful businessmen with people who has transformed lives all around the world, the first thing he does is focus on movement. And Tony's really right on this stuff. So what I'm going to say is basically, again, let's go back to this ACE receptor, okay? What happens is this. People, now everyone's like, oh, I don't want ACE2. I don't want ACE2. No. Actually, listen. ACE2, angiotensin converting enzyme 2, is an enzyme and a receptor that actually creates, it's an enzyme that creates essentially products that are anti-inflammatory, okay? So it creates basically signaling molecules that cause vasodilation, that lower inflammation in the body, protect the lungs against a huge inflammatory challenge, protect the heart. ACE2 actually is protective against whole body inflammation and local inflammation in the lungs. So what happens when you are sedentary? What happens when you are obese? What happens when you don't exercise? What happens if you have cardiovascular disease? What happens if you have high blood pressure? What happens if you have all these different, what we call comorbidities? Yep. What do they, type 2 diabetes, what do they all have in common? Inflammation. Now your body, it's just like a thermostat, okay? Your body is basically always going to try and fight to bring things in equilibrium. So remember, ACE2 is anti-inflammatory. If all these conditions, diabetes, obesity, heart disease, high blood pressure, they all have this in common, high inflammation. What else are they going to likely have in common? Studies are showing this, higher ACE2 levels. Higher ACE2 basically is trying to counter. It's trying to bring your body back into balance. So guess what happens? We talk about death with COVID. What happens is people who have these comorbidities have more ACE2. So COVID comes in, they have more places to dock. But guess what happens? When the COVID virus docks on ACE2 and it goes in the cell, it takes this enzyme with it. Yep. Now this enzyme can no longer protect the lungs. So you already have elevated inflammation. If you're looking at the scale, it's tipping toward inflammation. Now you pull ACE2 into the cell and ACE2 can't help anymore. Now the inflammation goes out of control in your lungs and you have what we call an inflammatory storm or a cytokine storm, which leads to death. Okay? So again, when I am sedentary, when I have all these problems, inflammation's up, ACE2's up. So that's one problem that's a serious problem. So we want to counter that by lowering inflammation. Going back to what Ryan said, basically, when I am sedentary and obese, my fat cells become inflamed. When fat cells are inflamed, like Ryan said, you have tons of ACE2 receptors. Mm-hmm. So now, not only are your lungs producing a bunch of this virus, the adipose tissue, your fat tissue, becomes a reservoir for the virus. It's replicating. So like Ryan said, it's lasting 5 more days sitting there. It's just sitting there producing more and more of this virus. So basically what we're doing with exercise, it attacks it on a number of different ways, right? Number one, again, when I talked about you have more ACE2, when you lower inflammation through movement, you don't have the need to have a bunch of ACE2 receptors. So people who are metabolically healthy and exercise all the time, they have lower ACE2 receptors, less places for the virus to bind to. Okay? 2, if I'm healthy and I've done a lot of and I've been exercising and I have low inflammation, let's just say you do get infected, okay, and you pull in ACE2 into the cell, you don't have a lot of inflammation anyway. So yeah, you get a little inflammatory response. It's nothing you can't handle. You basically get a flu, okay? Mm-hmm. You're not going to die. There's not going to be a problem. You're going to recover because you don't have a lot of inflammation. You don't get an inflammatory storm. So that's the second thing. So people who are metabolically elite or people who are exercising have lower ACE2 receptors. 2, they have lower inflammation, so they're not going to have a cytokine or inflammatory storm. Okay? But also 3, studies show that exercise, moderate exercise, healthy exercise, increases antibodies or these immunoglobulins. It increases them in your body, increases B cells, T cells, increases all these cells in your body, macrophages, all the cells that attack the virus. An exercise challenge actually upregulates those. It makes those higher. It increases anti-inflammatory, what we call cytokines, and decreases pro-inflammatory cytokines. Mm-hmm. So basically your inflammation is super low going in and your immune system's, I'm ready to go. Your immune system's ready to go because exercise challenges the immune system. Your immune system's being challenged all the time, so it's ready for an inflammatory attack or it's ready for an immune attack. Okay? So those are different ways basically that exercise. Now the biggest thing I'm going to talk about is it's got to be healthy exercise, right? Balanced exercise. So the way to think about it is if you're exercising to a point where you're improving, you're probably not overtraining, you're probably not overreaching. Mm-hmm. If you're exercising to a point like, for example, athletes during a season are going down and down oftentimes. Baseball, Brian played baseball, Brian won a national championship in college, it's a tremendous amount of games. Mm-hmm. You know what I mean? And so what happens is we did a research actually where we found that the same baseball team that he was playing for, they decrease lean mass, they decrease power, and also immune system gets challenged. So if you're training for a marathon, your immune system actually could be impaired. Yep. But if you're training for health, you're training moderate exercise health, you're able to improve, you feel good, you feel your recoveries normally anywhere from 7, mostly 8, 9 all the time from your exercise, that's strengthening your immune system. So those are things that I think you're moving yourself to become what we call metabolically elite. And if you're metabolically elite or you're metabolically strong, that's huge. Now, one thing I will say is a lot of people are thinking, man, oh my God, I'm obese. I can't change that overnight. Let me say this. Number one, yeah, exercise will lower body fat, and that will lower the reservoir. But when I was going to grad school, there was a huge craze, and it was called Fat and Fit. And I don't like using that terminology, but it was actually a huge exercise session at American College of Sports Medicine. Basically, they show that you could tease out the negative metabolic effects of obesity. If you took people who were overweight and they were fit, they actually didn't have a lot of these problems that we're seeing, that, for example, diabetes, impaired immune function, cardiovascular disease. Body fat, if you have higher body fat but you're really fit, your body fat isn't as inflamed. And so that's really, really important. So I think that, so you can instantaneously start to change and lower inflammation immediately, even though you have over body fat, just by exercising. And the last thing basically I would say that exercise does is, interestingly enough, exercise turns on this fuel gauge. And this fuel gauge in your body, which is basically called AMPK, it's a fuel gauge which says when your fuel's low, this fuel gauge turns on. And intriguingly enough, this fuel gauge actually can activate the ACE2 receptor and make it be more anti-inflammatory. So just movement makes the ACE2 act better. So if you're getting attacked by the virus, the exercise that you've done is making it work better, so you're not getting as impacted as much. That's the theory behind that. So one thing that I think that we want to say is this: think about it. Going back to the lockdown, lots of studies have shown that lockdowns drastically lowered physical activity.
Yep.
Okay. So if we are going to be pandemic proof, you guys are the elite, because you are taking your time right now to study how to change your body, how to change your family's body. What you can do is you can take this information. It starts with you watching this video, who's taking the time to go through this and teaching people principles of exercise. Moderate exercise at least 3 to 5 times a week. Improving yourself, like Dr. Ryan said, getting sun. These are essential to pandemic proofing us.
Amazing, amazing, amazing. And movement is absolutely essential, and you just heard that. And so the last thing I want to touch on, supplementation. There are studies with vitamin D3 are overwhelming. People who are deficient in vitamin D3, less than 30 nanograms per deciliter or milliliter, have a lot worse outcomes with COVID-19. That's been shown over and over again. There's actually a study in Spain where they infused vitamin D or a form of it inside of people, and they significantly improved. People that didn't get it were way worse off. Like, everyone should be focusing on going out and getting some degree of sunlight. The first rule of medicine is first do no harm. There's no harm in going outside, and as long as you're not roasting, and I don't think anywhere in the world you're roasting right now, but just go out, get some full body sun, and even if you can't, guess what? Supplement with vitamin D3, K2, 5,000 to 10,000 international units, and get your vitamin D levels up. That can help with inflammation. That is exactly what vitamin D is doing. Some other things, carnitine, selenium. There's a study with selenium showing that COVID patients that had higher degrees of selenium fared better. You can get that through red meat, right? Getting good sources of high quality meat is very good for selenium. Things like zinc. A good quality probiotic, which is controversial because a lot of them are out there are ridiculous, but improving overall gut health is going to improve immune function. There's actually a study and a proposal going on ketones. Ketones can help with the cytokine storm, the inflammation that's going on. But again, like the bare basics should be vitamin D3. Like, it's very affordable. Anyone can do it. And so to sum this kind of section up of what we talked about, I think the key is this: avoid processed carbohydrates. Lower the amount of sugar that you're eating. Eat as close to ketogenic as possible. We know ketogenic diets are highly anti-inflammatory and can really help with that. Minimize highly inflammatory seed oils. A lot of people are cooking. Hopefully you're cooking at home, maybe cooking stuff, but avoid a lot of those seed oils. High omega-6 seed oils are highly inflammatory. And then do something known as intermittent eating. People refer to it as intermittent fasting. Listen, the easy way to remember it is like, eat when the sun's out, don't eat when the sun's down, right? Very simple way of thinking about, oh, when should I eat? Should it be 16 hours, 20-hour fast, all these different things? Listen, at bare minimum, just eat when the sun's up and don't eat when the sun's not up. And then try and condense that eating window and focus on eating less refined or processed foods. You will fare off way, way, way better. We talked about movement, right? How to incorporate in movement. If you can go do some form of resistance training, some form of high intensity interval training, at bare minimum, go out and get 10 to 15,000 steps a day and just start moving your
100%.
Body to increase just overall
100%.
movement, right? And then last thing is supplementation. Bare minimum, vitamin D3. If you don't get enough sun, vitamin D3. Some other things, again, things that control blood glucose, things like berberine. You could do cod liver oil to get in some of those other vitamins. Exogenous ketones can be a great one, and some probiotics as well. So, organ meats as well. I actually hate organ meats. I think they're just too gamey for me, but I've actually started taking a pill that has like liver, heart, kidney in it just to get some of those other vitamins in there as well that have been shown to help.
Smart.
That was a lot. Is there anything else that you want to add? Are we good?
No, I think obviously stress techniques, making sure that you're
mitigating stress,
sleeping well.
All of these things, right? All of these things. And these are things that are available inside Keto Club that we talk about all the time. Yeah. But again, the thing is this, and I hope you took a lot of notes. This was a long session. I know it was a lot of information. And this is going to be available for you to watch over and over and over again. And things will adapt. By the next time you watch this, there might be new data out there. But guess what? That's the beauty of science, is hopefully there is new data out there. But the general principles that we talked about today, the data that's currently available of like, what can we do? How severe is this? What are the vaccines? But most importantly, out of the entire thing is, what can I do today to make metabolic health a priority and focus on getting myself, my friends, my family in the best position possible to improve immune function and battle not just COVID-19, but COVID-20, COVID-27, COVID-99, anything that comes at us. It starts with focusing on improving metabolic health. That's it. Appreciate you guys for tuning in. Love y'all, and we'll talk to you soon.
Thanks, guys.